Okay, so we have a 3 months old boy who's developed a runny nose and a bit of cough 2 days ago and has become progressively chesty. He wets fewer nappies as a result of this illness. The other two siblings also have colds. He had no neonatal problems at all. On examination, he's febrile with temperature of 38 degrees. He's got copious nasal secretions and a dry, wheezy cough. Respiratory rate is 56, with tracheal and intercostal and subcostal recession. On auscultation, there are widespread fine crackles and expiratory wheeze. Cardiovascular and abdominal examinations are normal. So I'll give you 5 seconds for you to pause the video and come up with your diagnosis and what's your initial management and what's the most likely cause of this presentation. Okay, so uh, the correct answer in terms of diagnosis is bronchiolitis. So let's just go through the other options. So we have acute exacerbation of asthma. So do we see any features suggesting of asthma? So firstly, let's look at the age, because remember, asthma in 99% of patients happens after the age of 2, but our patient is only 3 months old boy. And also we would have to see any signs or symptoms of atopic, like atopic dermatitis, which is the skin conditions, or even family history of asthma, none of which we see in this case. So we can easily rule that one out. And then we've got croup. So classically, for the sake of exam, croup is associated with relentless cough that is always described as barking cough. But uh, do we see that barking cough in this case? No, it is actually wheezy cough, and so we can easily rule that one out as well. Laryngomalacia. So this is an interesting condition. Laryngomalacia. Uh, there are some clinical features suggestive of laryngomalacia, such as the way the boy is breathing. So, uh, so like expiratory wheeze here. But then laryngomalacia, let's just talk about that really quick. So laryngomalacia is when the larynx collapses and narrows during inspiration, and when there is a negative intrathoracic pressure resulting in inspiratory stridor. It is usually a benign condition with noisy breathing, but no major problems with feeding or significant respiratory distress. And most cases resolve spontaneously within a year as the larynx grows and the cartilaginous rings stiffen. So really, laryngomalacia is uh, paralysis, if you like, paralysis of the larynx or the cords. And a very important diagnosis in the case of laryngomalacia is a hemangioma in the upper airway, because remember, the majority of hemangiomas are single cutaneous lesions, but they can also occur at other sites such as the upper airway, and they can enlarge with potentially life-threatening consequences. So we can easily rule that one out as well. So cystic fibrosis. Do we see any features of cystic fibrosis? Yes. So there's copious secretions as well in cystic fibrosis, or sometimes there isn't. They can become ill. The most common cause is Haemophilus influenza. Uh, but then for cystic fibrosis, we would have to have more information to diagnose. For example, the clinical history will say they have recurrent chest infections, none of which we see that in this case. So we can easily rule that one out. Now, in terms of initial management, what's the initial management? We do that with conservative management, okay? Amoxicillin or co-amoxiclav, they're given if our patient becomes really unwell with super added infection. So we can easily rule those ones out. Do we admit them urgently and intubate? No, it's not really a sinister case, so no, we don't do that. Now, in terms of salbutamol nebulized, there is no evidence that inhaled bronchodilators, inhaled adrenaline, oral or inhaled steroids, inhaled hypertonic saline or leukotriene receptor antagonists that can modify the clinical course or any important outcomes such as the need for mechanical ventilation or the length of hospital stay. So there's no evidence for those. So we can easily rule that one out as well. Now, in terms of the cause, 80% or maybe even 85% of bronchiolitis is caused by respiratory syncytial virus. So that's the correct answer. Yes, rhinovirus can be a cause as well, but that is not the most common. Okay, the rest, no, so you can easily rule those ones out. So now let's learn a bit more about bronchiolitis. So the clinical features are that the patients are characteristically, this is very important, characteristically are under the age of 2 years. They're obviously febrile with a lot of nasal secretions. That is also a key piece of information. The wheeze is dry. They can have high temperature with tracheal tug, intercostal and subcostal recessions. Pathology, like we said, 80% of cases are respiratory syncytial virus. Investigations is mostly clinically judged. And investigations are rarely required apart from a nasopharyngeal or nasopharyngeal aspirate. But that's not really routinely done. Like I said, it's mostly clinical judgment. So in terms of management, so it's again mainly supportive. However, we do sometimes give them or have to give them pavlizumab, but then this is extremely expensive and it's only reserved for high-risk groups of patients, such as those infants who are a survivor of prematurity. And there's no vaccine for it, but then we do, again, it's clinically judged. We do admit them if they deteriorate rapidly, especially if they're under the age of 2 months, or have a temperature of more than 39 degrees. So, hope that was useful.